the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Thank you. So before I start my session, I would like to thank Dr. Pothiraj Pitchai, the principals of Sancheti College of Physiotherapy, for organizing such a wonderful web series, webinar, a series of webinars. And also would like to thank Dr. Suroshri ma'am, the professor and head of the department, for giving us opportunity to deliver to talk on this topic. Also, would like to thank our principal, Dr. Shweta Manwadkar, for her constant support and encouragement to give us the best. And thank you, Dr. Mayur, for the wonderful session. And now we'll go to my area. Now that he has covered all the aspects of what are the changes that is taking place in the postnatal with respect to pelvic floor muscle. And sir has rightly mentioned, there are so many changes are taking place in the pelvic floor muscle. So the pelvic floor muscle dysfunction, it is seen commonly out of the childbirth. It has been considered, the pregnancy and the childbirth are considered as the independent risk factors for developing pelvic floor dysfunction, whether it is FTND, irrespective of whatever the type of delivery mode that has been conducted. They are bound to affect the pelvic floor muscle, going to cause certain amount of dysfunction. So the American Physical Therapy Association, APTA, has classified this dysfunction into 4 types. One is the pelvic floor muscle can go for a hypotonous dysfunction or hypotonous dysfunction, incoordinated dysfunction, or visceral dysfunction. In this topic, what I am going to highlight or touch about is a hypotonous dysfunction, which is commonly going to develop with during the postnatal period after the delivery, and also the incoordinated dysfunction. These are the commonest dysfunction that has been seen immediately after the childbirth. Okay. And so, as sir has also rightly mentioned, what are the changes that is taking place with respect to the pelvic floor? And Fonte et al. In 2009 is also listed of the same thing about, irrespective of a type of delivery, one can land up in developing a genital tract trauma or pelvic floor muscle injury, or postpartum urinary incontinence, or potential nerve injury, or anal incontinence after the childbirth, or pelvic organ prolapse or sexual dysfunction. These are the broad areas where one can expect to develop part of your pelvic floor dysfunction. Now, can you tell me what are the common? Okay, before we'll move into this, let's see the prevalence of this pelvic floor dysfunction in the postpartum women. The prevalence is really high. Study done by Rohil et al. In 2019 in Delhi. What he found is the prevalence of almost of 20.7%. That is 80 people out of 385 participants who developed a pelvic floor dysfunction after the childbirth. So he said it is almost 1 out of 5 women who likely to develop a pelvic floor dysfunction, and which can cause into various other problems. So he also mentioned, based on his study, the urinary incontinence, where there is almost a 10.6% likely to develop urinary dysfunction. Fecal incontinence is almost 8.6%. Flatus incontinence again 11.9%. Pelvic organ prolapse 1.6%, and some sort of pelvic floor dysfunction is 20.8. So irrespective of whatever the type of delivery, some would likely to end up of this pelvic floor dysfunction. Again, the type of dysfunction varies from region to region, and still there is a limited evidence that is available to support, okay, what is the common prevalence of this dysfunction that likely to take place. There are many factors, risk factor that is associated with this pelvic floor dysfunction. And there is one more systematic review on meta-analysis which I come across, irrespective of what are the type of delivery that is being taken following vaginal delivery or cesarean delivery. And in this study, Bartha et al. In 2021, what is concluded is the prevalence of pelvic floor dysfunctions almost double in vaginal delivery case as compared to the cesarean delivery. And urinary incontinence is more than twice likely to take place for vaginal delivery as compared to the cesarean delivery. And pelvic organ prolapse, again, it is 3 times higher the risk, and anal incontinence, again, slightly less than 2 times as compared to the cesarean delivery. So what does it mean? Irrespective of what are the type of delivery, one likely to go for this pelvic floor dysfunction, but predominantly the the vaginal delivery or with episiotomy will likely to land up, they are more to develop pelvic floor dysfunction as compared to the cesarean delivery. Okay. And so now that I just want to interact with the participants, I'm sure everybody, we have a PG students, and then we have undergraduate students. You all must have been to your clinical posting where you must have interacted with your patients. You must have had your women's health posting. What is the common problems or the barriers that you face while delivering your ANC program or PNC program? Can participants share your experience? I'm sure the women's health physiotherapy is growing now. There's a little bit of awareness is coming up, but still we are in the very primitive stage, and where the awareness seems to be very less, and there is a lot of barriers that we come across. Thank you. There is a weight gain, incontinence, lack of awareness amongst the patient and family members. Complaints to access will be difficult. Okay. Any other barriers that you all found? As a therapist, why are you able to deliver your pelvic rehabilitation after the postpartum, or is there any fear to exercise? Okay. Anything else? Consent is a problem. Misconceptions, yes. Apprehensions, yes. There's a lot. Thank you so much, audience. And there are many factors which affects while taking physiotherapy services after the postnatal, during the postnatal period. One such major problem is what we encounter is slide is not changing. Okay. One such problem is the major problem is there is awareness of postnatal exercise among recently delivered mothers. This is a study done by Kaur et al. In Punjab in 2020, and where he found almost 82% of the participant in this study is not at all aware about what is this exercise or what is supposed to do after the delivery. Awareness is very minimal. It's not only here, even in the western countries the scenarios are most similar, where the awareness is less, but when compared to India, they're little better, I would say. And there was one more study also, which I come across, Ed et al. In 2021, about the barriers to exercise in postpartum women. And so, what are the factors? There are many factors that has been identified, and that can act as a barrier for them to participate or for them to take physiotherapy services after the childbirth delivery. One is based on the intrapersonal factors. Among the intrapersonal factor, the major problem which has been identified was a tiredness or lack of having a disturbed sleeping or lack of sleeping. That is because the woman must have been just delivered, and must have had a long labor period or the surgery, whatever it is. So during that phase, it's very difficult for them to start initially to cooperate, to understand, and if you're going to meet your client at that point in time. So that is a major problem that has been anticipated. And the second one is, if you look at it, this is a low motivation. Students, irrespective of whether the participant is educated, highly educated, or having a low educated or from the low socioeconomic group or the high socioeconomic group, there is always a little bit of the motivation factor which is found to be very low in this study. And third one is about interpersonal factor. The most common problem is time and for unpredictable routine schedule, because now that the baby is delivered and we don't know the routine of the baby, when the baby will get up, when it will cry for the milk, when to change the nappy changing. So the entire house, it's not only the mother, the entire the situation in the family will change. But the routine, to understand what is my routine, when I can find time to do exercise, that becomes a very challenging. That is another one of the big barriers that as a woman's health physiotherapist you might come across. And next one is busy with domestic chores or the responsibilities. Sometimes it is so common among the rural women, and I have personally witnessed in my village town where the people, she has gone for a delivery, that happened to be a full-time normal delivery. Next day, she returned to home, and then I saw her lifting a heavy water pot on her head, and she was walking. I was shocked, like after the delivery, how one, so I was literally shocked. And that is what, because there is no a person in the family which she need to do it. So likewise, there are many household work which expected for the mothers to, carry out even after the childbirth. So, so they're busy with it. There's no time uh, to make it available, for them to engage in any physical therapy. And the next one is about the family support. The major among all these risk factor, which is a socio-cultural demographic risk factor, the major one is found to be a lack of support from family, friends, and other members. It may be from say the husband or the mother-in-law or the mother or the family member. There is no support unless and until the woman has been supported, the family support is given, she won't be able to make it for your rehab program. So there is unpublished data article. I remember one of my colleagues who was done, Dr. Jyoti Parle, my ex-colleague, and she has done the role of husbands in the postpartum period, where you have to make the husband or the family member part of the rehab program. How one, so that they understand what is the pain that she is now likely to go through, how they can support her to make the delivery easy, as well as they make the rehab program post delivery also successful. So this is another very important barrier that has been identified. So what is the take home message from here? Because we have seen there are so many barriers that has been identified. So our role comes, it's not after the delivery. You have to start identifying these barriers well before the during the ANC period, and you need to start addressing these barriers. If at all, if your client has any of these barriers, you should be able to address and make a strategy to overcome all this barrier, so that they will be able to participate in the rehabilitation program. Okay, and then so now that we know that we have seen there are, irrespective of what are the type of delivery, pelvic floor muscle likely to go for a dysfunction. Dysfunction can be of many types that we have seen. Okay, so how to go about it? How to screen this? Whether your client has got a pelvic organ prolapse, or your patient got an incontinence or sexual dysfunction. What is the problem? How to do it? So what you can do is, we have a simple screening tool. Barber et al. In 2005 was introduced about a pelvic floor dysfunction inventory, which is a 20-item short form scale, where he is talking about pelvic organ prolapse and colorectal anal distress inventory, and then urinary distress inventory. So based on it's a very subjective, and based on that, if the patient saying yes, I have a problem, then you're going to grade them. How far do you feel? So okay, so based on this, the total score is almost 0 to 300. Higher the score, higher the pelvic floor dysfunction is possible. Lower the score is, the less amount of dysfunction. So this is another one of the very useful tool that can be used during the your routine postnatal rehab program. And immediately, as soon as you take your PNC cases, and this can be used to identify whether your client or your patient is likely to has landed any of this dysfunction. Okay, and so what is the solution? Now everybody is going through this, likely to go through this. Maybe the sequence will differ, where the dysfunction may be differ. So what is the solution? What shall we do? So what are we supposed to do? So the thing is, what you're supposed to do is, what Makama et al. In 2021 also identified about some strategies how to overcome these barriers, where they can participate in your pelvic floor rehabilitation program post-delivery. So he has identified it based on the 3 factors. One is a capability, which is a barrier and facilitator, and motivation factor and opportunity factor. For example, capability. There is a lack of knowledge regarding benefits of lifestyle behavior. So as a strategy, what you're supposed to do is, as a pelvic floor therapist or women's health therapist, you have to educate a patient. You have to literally, have your own strategy, how you want to sensitize, whether you want to show them a video, or whether you want to show them a charts, or the pictures, or whatever you want, whichever that means that can create an impact effectively on your patient. Use the particular strategy and show them, how the changes likely to take place after the delivery. And so once you give that information, then you have to provide that, okay, these are the changes likely to take place. So, and there is a solution to it. So what you can do is, you're going to educate health, health education about the lifestyle of the benefits of physiotherapy exercises or the pelvic floor exercises post delivery. So when you create that, so here in the strategy management, it has been addressed for the woman, the population itself, and for the policy in terms of, you need to make sure that the woman is able to access to the hospital. Unfortunately, in India, the woman will come to delivery to her mother house, maybe at the month of 7th month, or at 8th or 9th month. They will be there for a short period, but then again they go back to the husband house. So for you to access to such patients, again, there is going to be difficulty. Sometimes for some patients, it won't be possible for them to access to the healthcare also, which is possible for the rural population. So what policies can be developed? So there is a policy stakeholder also. There is some suggestion, strategy that has been advised, and health providers like doctors, as physiotherapists, and so on. How we can, what are the strategies? We as healthcare providers, how we can educate, and what are the things that can be delivered to the patient that can be addressed. So these are the 3 strategies, 3 levels for the motivation factors. What is the strategy, and how to which target population that can be targeted to bring about some changes in the awareness level. So these are the some of the strategies. Probably you can go through this later, and you read it, you will understand. And moving on to the next, and before I talk about a little evidence about what is this pelvic, the role of pelvic floor muscles in in the dysfunction, and we need to understand what is the connection to the pelvic floor muscle to the other muscles. I would like to, I remember my senior, my teacher, Dr. Bharati Bellare, she always says that this pelvic floor muscle is like, it's called abdominal capsules. If you look at this, on the below you have a pelvic floor muscle, anterior you have a transverse abdominis, and posteriorly it is being connected with the multifidus, and superiorly it is being connected to the diaphragm. So it is being connected to with each other, so it looks like a capsule, and it has been well connected, so that if there is any change in anywhere in whether the diaphragm or the pelvic floor or the transverse abdominis or multifidus, it is going to cause a dysfunction in other structures, because they are all connected in series. So if there is any dysfunction, which is going to directly affect your pelvic floor muscle, and which is going to cause a dysfunction. Okay, and if you look at this, so there are many factors which can affect the pelvic floor dysfunction, following during the postnatal period. One such common problem is this increased intra-abdominal pressure. When the pressure is so much, then what happened? Generally, what happened? All these intrinsic muscles, the core muscle, which is being connected to the pelvic floor muscle, they coordinate with each other and they provide support to the trunk, or also they help in evacuation. Either when the intra-abdominal pressure is very high, when the force vector is directed, when the force vector is moving upward, and you will evacuation in the form of vomiting, that will take place, or if the vector is going towards the pelvic floor, and which will cause evacuation of the fecus or the urine. So that will take place, or so it depends upon the force of the vector, in which direction they are allowed to move, and the particular function is taking place in the abdominal pelvic cavity. And so during inspiration, what happens? During inspiration, the diaphragm descends. Okay, when the diaphragm descends, the abdominal wall is will push out, and then the pelvic floor also will move down. And during exhalation, what happens? Goes in the reverse action, where the transverse abdominis will move towards the trunk, and the diaphragm will move upward, and the pelvic floor muscle also move upward. And so when the intra-abdominal pressure is more, and especially that happens because there is already compromised of your diastasis erectile post delivery. Okay, so there is some dysfunction that is going to take place in the abdominal capsules, and or when there is whenever there, if you are doing the postnatal, if your patient has got a constipation, when there is increase in abdominal pressure, which is going to further affect your pelvic floor muscle, which is going to cause further damage to the muscle, and is going to cause pelvic floor dysfunction. So there could be the coordination dysfunction between this intrinsic and the extrinsic muscles, which can cause a dysfunction, or increase in your intra-abdominal pressure can also cause a dysfunction to the pelvic floor muscle. And another one important factor, as we all know, during the pregnancy, the posture of the pregnant woman changes, isn't it? And so we all know there is a lordosis, there is anterior pelvic tilt, all that is going to take place. So if you look at this in the normal, this is the image that shows about the normal, women. So the coccyx and the pubic bone, the pelvic floor muscle, which is attached to the pubic bone, to the coccyx, when they're attached in a particular way, they incline. Okay, so whenever there is a pressure that has been generated in the abdominal cavity, they hit the abdominal wall, and this vector force will hit to the sacral bone from which will again act as a percussor, because the force should not fall on the pelvic floor muscle. If at all, if there is any force that is falling on the pelvic floor muscle, the entire biomechanism is going to alter and going to cause a dysfunction normally. So once the force is hitting the sacral bone, Again, the force will be redirected to the pelvic bone, the pubic, and from the pubic it will be redirected to the coccyx, and they will disappear, or the force get absorbed. So in this case, in the normal scenario, what happened? The pelvic floor muscles escape. There's no damage, so it's a normal function. But what happened when there is a so do you think the posture is altered postnatal during the postnatal period immediately after the childbirth? Yes, definitely, because sometimes what happens, the subject will either because of the lordosis may be reduced. When the lordosis is reduced, or any other changes in the upper trunk which will alter the position of your pubic bone to the coccyx, then the orientation of your pelvic floor muscle between these areas also altered. Then what happened, whenever there is an increase in the abdominal pressure, the vector force will hit on the sacrum, okay, and then it will come to the pubic bone. Instead of hitting the coccyx, it will hit the pelvic floor muscle. Whenever there is a dysfunction and there is more intra-abdominal pressure, then what happens? The pelvic floor muscle stuff, pelvic floor, the muscles are prone to have, will have more amount of force, and that will weaken the muscle further and increase the laxity and cause the dysfunction. So the posture also very, very important factor that you should screen immediately after postnatal period. If there is any change in the posture, that you should make the correction. You should make the do the changes. So what we should do in the postnatal period, now that we understand, irrespective of whatever the type of the delivery that is woman has gone through, pelvic floor dysfunction likely to take place. And so what you're supposed to understand is that there are the posture that you should screen, and the breathing pattern of the pregnant woman. I mean the postnatal woman should be, you should assess, and also the lumbar pelvic pain. So as I said earlier, so when the abdominal capsules are well connected with each other, they are in series. So if there is any changes anywhere in the structure, if there is a low back, because commonly also must have come across people with a low back pain after the delivery, if any pain or pelvic girdle pain in the extremity can also, because it will alter the biomechanics of the lumbosacral angle, and that will alter the position, inclination of your pelvic floor muscle, that will cause further dysfunction. If that is the case, you have to address the lumbar pelvic pain, and then so that you will be able to minimize the stress on the pelvic floor muscle. Okay, so these are the three factors that, apart from, I'm sure like all the TGs and undergraduate students will be evaluating during the postnatal after the childbirth, where you go for the breast examination, and then abdominal examination, as well as your pelvic floor examination. Along with that, what you need to include is assessment of the posture, and then breathing pattern of the subject. Is there any coordination? Is because diastasis recti anteriorly, if say LSES was when a client was undergone for a surgery, so along with the diastasis recti, there is an incision that is coming that way, that is going to hamper your core muscle, okay, and also there is a weakened pelvic floor muscle, which will cause a dysfunction in the diaphragm function also. So how is the pattern of that breathing? So is it smoothly and coordinated? So is the motor control perfect? Can you go ahead? Yes, then work on the other deficit. Otherwise, you have to include the breathing exercise and assessment of your breathing assessment. I mean, the respiratory assessment has to be included for your assessment, right? So so in the postnatal posture, what you need to understand the postnatal posture, because of the changes after the delivery, and there is a increased amount of, there is an anterior pelvic tilt that is going to take place, which is going to cause further damage, for the biomechanical changes in the pelvic area, okay, and that is going to affect the pelvic floor muscle, number one. Number two, in the postnatal period, I'm sure you can relate to this image, like whenever you go to postnatal ward after the delivery, because of poor infrastructure in some places, what happens, patient need to sit on the couch, okay, there is no proper support, and they forced to lean forward and then do the feeding to the child. So there is already there's a breast are heavy, and there is a protracted shoulder because of the changes during pregnancy. In addition to that, they need to feed the baby. So when the woman is forced to feed up in a stoop posture, the biomechanics of the lumbar spine and the lordosis, everything is changed. Also, the lumbar, if you look at the lumbar area where the lordosis is obliterated, there is a flattening of the back will take place. Again, that is going to cause more stress on the pelvic floor muscle, that is going to cause dysfunction. If that is the case, you need to tell them, you need to assess, you need to educate your patient how to sit rightly, how to retract the shoulder, and then feed the baby with the right feeding position. Okay, and secondly, about the lumbo-pelvic pain or a pelvic pain, there is another factor women do post delivery. Women like to develop. And during it all, and what he found is about the fatigability of the lumbar-pelvic stabilizing muscles in women 8 and 26-week postpartum. And he's done this study in 2018. He just wanted to understand how after the delivery about his, the core muscles in the lumbar-pelvic region, how they are they really fatigue, are they, really weak, and how they are recovering. So what he found in this, here's I think if I'm not mistaken, has done almost 300 patients on which he has been observed. And so what he concluded is it's a greater amount of fatigability of the lumbar pelvic stabilizing muscles and lower physical functioning because of there is a compromise in the core muscles, the functional activities, everything is being affected and is bound. That is a lower physical activity. Number two, and secondly, what he recommends is you have to assess the core muscles assessment in your function. Apart from otherwise of the abdominal examination, we just measure only the diastasis recti and what is the strength of the diastasis recti. No, you have to the multifidus is poor guy, he's been missed out completely from the assessment. Make sure you including him also as well as your diaphragm muscles. Okay, so he recommends assessment of a core muscle function and fatigability after the pregnancy and childbirth. And what he used in this study, he like in order to check the fatigability of the muscle, he used a active SLR fatigue task where the patient is asked to lie in supine, allow the patient to raise his leg, the entire leg, okay, with the knee in extension, at about 20 centimeter of the plinth. Okay, so the test is said to be the fatigability is said to be positive if the patient is failed to maintain, when the heel height is less, it's a mistake, when there is less than 10 centimeter of the plane. And while doing this procedure, the biofeedback has also been inflated about a 40 Hg pressure and then be placed on the pelvic, on the multifidus. Okay, and so while the patient is lifting, the pressure has been exerted on the cuff also is being monitored. So it depends upon how much the one is able to lift and what is the pressure that he is able to maintain on the cuff. Based on that, it has been cutoff has been set. So if the patient is not able to more than 10, not able to lift more than 10 centimeter, now if there is a more changes of, more than 20 millimeter Hg changes in the pressure level, then the patient said to be, the muscle said to be fatigue. This is a recent one of the techniques. So, the PGs can make a note of it and they can probably include in your recent evidence assessment and plus appropriate treatment strategies. And so coming to the next one, and another one interesting study. So there is a lot of physiotherapists, the role of physiotherapy or the pelvic floor therapist or women's health therapist, not just the Kegel exercise where everybody thinks about, okay, what are you going to do? It's not about the Kegel exercise, it's about the improving the motor control, it's about improving the core muscle, and then, plus along with the Kegel exercises. Okay, and so there's a study done by Dr. Kala et al. Along with Dr. Professor Bellary ma'am, 2019. Awareness about exclusive role of postnatal physiotherapy. About what is the awareness level? Because we know at least to some extent we are getting a referral from like orthopedician or from the neurologist or a neurosurgeon. Okay, therapist can be of helpful for their patient. So we are getting a patient, whereas at the women's health in the setup in the clinic, we always, and I'm sure student can relate to this, we will go to the like ANC OPD, will say, sir, please refer the patient, or we'll go to the PNC, can you please refer the patient, we have a role to play. Okay, so they wanted to probably, I think keeping that in mind, probably they want to explore what is the awareness about our, postnatal physical therapy among the obstetricians. So this study has been done around, around the Aurangabad in 2019. What it has been found was the awareness among the doctor was very, very low, and because of that, the referral also was very, very poor. for postnatal physiotherapy. So the take-home message is, as a community therapist, as a women's health therapist, as a pelvic floor therapist, you have a huge role in sensitizing all the stakeholders, right from your pregnant woman to the family members and the medical practitioner. It's your role. You have to create awareness. You have to sensitize, and say that you have a role to play. Then the patient referral will come. The patient will be able to participate. And I would like to say one more thing is another commonest challenge that what we encounter in the pelvic floor rehabilitation is, after the delivery, if it is FD&D post-delivery, the patient is there for a day or two, then the patient disappears, and after that, there is no point in getting the patient back to your physiotherapy program. Or even if it is LSES, again post-discharge, it's going to be a difficult task. But as Mayu sir rightly said, you have to start belly floor, on the fourth trimester, and then you need to, continue to improve the tone of the muscle, to get the motor control and so on. So because that is a challenge thing, because we are not able to get a patient after that. So what I would suggest and recommend, in fact we are also planning to implement in our institute, is a post tele-rehabilitation program for this all this postnatal women, where you connect them at the hospital. All patient will respect you, once you seriously, sincerely explain the sequence of the problem, what they like to develop. I'm sure if you explain them, no patient will say मुझे नहीं करना है. They want to improve, because they need to improve their health properly. They want to plan the future family also and so on, right? So you are the stepping stone to create that awareness. Maybe the tele-rehab is the one, which I'm hoping it is going to be helpful in connecting to those women post delivery, where we will be able to implement the postnatal physical therapy properly. And so the take-home message is, how to protect our pelvic floor muscle is, now you exhale during lifting activities, especially when you're carrying child. Otherwise, we think that we inhale, we try to lift the child. That is going to harm your pelvic floor muscle. You educate your client while lifting. You have to tuck your abdomen in and then exhale, and then you carry the baby. Okay, so that way you're going to protect the pelvic floor muscle. Avoid excessive coughing. If your patient is going to cough, try to identify, try and see what is allergens. Okay, if needed, you need to refer them to a physician and try to get that sorted. What are the respiratory conditions that are there, that is to be taken care. Otherwise, it's going to affect the pelvic floor muscle. Number 3, maintain a healthy body weight. Even post-delivery, that is another challenging one, because the more amount of the mass in the abdominal cavity, which is going to cause alteration in the biomechanics, which is going to affect the pelvic floor muscle. So, the study was done, almost a reduction of 3 to 5% of the body weight, which is going to save 50% of your pelvic floor muscle. So it is very important. That is another one of the long-term goal for your postnatal period. And avoid constipation. You should encourage the patient to get into healthy eating habits, fiber-rich diet. So probably you can take advice from the dietitian, and exercise your pelvic floor, exercise and the core exercise muscle, and rehabilitate for any other injuries like your low back pain, or hip pain, or if there is a sacroiliac dysfunction, or pelvic girdle pain, whatever the pain, the injuries that are associated. So this way, we will be able to prevent the pelvic floor muscle, and a woman will be able to be safe on her head. Thank you so much.
Thank you, sir. Thank you, Mayur sir and Pothiraj sir, for such a informative and insightful session. So we will, if you both allow, can we quickly take a couple of questions from the chat box?
Yeah, sure, we can do that.
Yes. So, good afternoon, sir. As far as postnatal phase is concerned, won't it have physiological changes or hormonal impact on muscles? So shouldn't we wait till puerperial recovery phase gets over? That is the question. But I'm just confused. It is specific to, I assume, for pelvic floor muscles. So somebody is asking that in postnatal phase, because still there are some physiological changes or hormonal changes taking place in the body and in the muscle, pelvic floor muscle. So shouldn't we wait till puerperial recovery phase gets over to start with any exercises?
Okay, so I would say that exercise that we are going to start are very simple and safe enough when we are talking about pelvic floor contraction. Or I think there was one question with regards to when do we start the core exercises for LACs, somebody who has got lower segment cesarean section. So it is just a core activation. It's not that I'm going to start with the abdominal curl-ups, which is going to put a stress on the sutures or anything, but just activating those cores is going to maintain the muscle contraction. Well, something similar is a static quadriceps, if we can relate it with regards to that. So it's a static contraction that is happening, no dynamics that is working there. So that those exercises are very much safe, rather indicated in the initial phase. And as the progression, later on, we can go with the dynamic version of exercises.
I guess that answers the question too, sir. What about LSCS? Can we start Kegels immediately after that too? So I guess it answers the question very well, that there's a difference between activation and strengthening. So here we are looking more of activation, and later when the phase gets
later period we progress.
Because during that period the muscles are under a lot of stress and relax. So you won't be, even if you intend to generate a strong contraction, you won't be able to. So it is like a firing of the muscle fibers, so they are intact. Otherwise, the pelvic floor muscle go for atrophy, which in turn further cause a dysfunction. So it's just activation of the muscle fiber.
Totally agree, sir. So a person is asking that when do we do per vaginal examination after LSCS?
Okay, so again, per vaginal examination, I would say that it would be only indicated, first take the history. On history, if the patients are having signs and symptoms where you feel that she's having urinary incontinence or prolapse, then only go for a per vaginal examination. It is a very sensitive examination. Do it only when it is utmost required. Otherwise, there is no need of doing per vaginal examination. Now, in that case, when it is required, generally she would have not come up with these problems in the initial 1 week. So we can wait for a 1 week or 2 weeks time period, because it will take at least a week's time period for her to settle down into the new changes that are happening to her body. The presence of the baby itself is going to change her life from 360 degrees. There is too much of a demand that the mother goes through, and which she is not able to cope up in the initial 2-3 days time period. So I would suggest that it's good time to wait for 1 week. After 1 week, if it is only required, at most required, then only do it. If on history, on your observation, if there is no frank weakness, do not do for the per vaginal examination. For your assessment, you can do a palpatory method.
Exactly.
Yes.
Keeping the hand on the perineum.
Yes. So coming to the palpatory method, the next question is on that, sir. How to grade for palpatory method?
Okay, so the palpatory method also we can grade it using the perfect score. Using the keeping the hand on the perineum, we can still do the perfect method. So again, it is a subjective method. It's not an objective tool where we can exactly quantify. It will vary from therapist to therapist. Over a period of experience, it is better. The only key point here is it is always advisable that the same therapist, generally in the teaching institute, it so happens that the posting of the student changes and some other student is evaluating and re-evaluating the patient. So that will give us a variation. So if the same therapist does it multiple times, he will be able to differentiate the difference amount of a contraction.
True, very correct, sir. So with this, there is one last question, which is a very interesting one, going by today's time and COVID period. How to ensure proper pelvic floor muscle and core activation via the tele-rehabilitation mode?
Yes, ma'am. It is going to be a challenging one. At least what you can do is there are simple exercise videos can be supplement in the tele-rehabilitation. That is the one positive factor, that at least what is required is the patient. The advantage would be if you are interacting with your client in the antenatal care. So already you've been taught about what is Kegels exercise, pelvic floor muscle, how to activate your core muscle. So nothing is new. So once even after 8 weeks post delivery, where actually you can start working, improving, you can intensify your exercise and start. So it will be better if you are meeting your client in the ANC period where already patients been sensitized how to do it, so it will become easier. Or if you're going to use it for the first time, we at least need to have a minimal contact period. At least you should say whenever you're coming to hospital for vaccination time, that time you come and meet me. Meanwhile, the simple exercise which they can do, that is what the community therapist is supposed to do. So which can be done without any dysfunction, which is safer. We can nowadays we have a lot of videos, images, and that can be supplement. So that is additional information.
Right, very rightly said, sir. Here you pointed out two things: that first point of contact or minimal point of contact. You have to have an offline session at first.
Yes.
And then a follow-up can be done, few follow-ups can be done through tele-rehab. And at the same time, we must utilize our educational resources like pamphlet, whatever, however.
Yes.
So thank you so much, sir. And as Apur sir said that, although, and I feel it is great that now our country, this shows the progress of our country, that men like you are discussing about pelvic health in women. And I think it is wonderful. And because of this sole reason, I think we are hopeful that this will reach to families, and
definitely
that myths and taboos are broken soon, especially after the childbirth, when all the focus is on the child and hardly any focus on the woman. So with this, we end our today's webinar, and we wish both of you a very wonderful day. And thank you, audience, for being so patient and
thank you.
giving us wonderful questions.
Thank you, everyone. Once again, we would like to thank both of us, Sanchiti team, for giving us the opportunity to be here today and share our experience.
Thank you so much. And thank you for the lovely participants. Thank you so much.
Thank you so much.
Take care, everyone. Bye.
Yeah. Bye, everybody.